Naveen sir, you are kindly requested to make me the co-host, sir.
Please, good evening, Dr. Vishal. It is
Good
now
evening.
being live streamed and over to you.
Thank
And
you
we
very
can
much, sir.
start the proceedings. Okay.
Right, sir. Thank you very much, sir. Over to you, Dr. Vanita, ma'am. Please start the webinar, ma'am.
Okay. A very good evening, dear all. Today we have all joined here together for the RSA academic webinar, which is being organized by the RSA Chandigarh branch. And the theme of today's webinar is cancer pain and symptom management. So I would like to thank our President, Dr. Naveen Malhotra, sir, Dr. Vishal Singla, Secretary, RSA, who have, given this opportunity to Chandigarh to host this webinar. And today we have sessions on pro and con, as well as a panel discussion. So I welcome you all for this webinar, and I invite our President, sir, and our Secretary to say a few words on this occasion.
Good evening, all. It's a pleasure to address you all as President of Research Society of Anesthesiology. And I'm very happy to note that under the leadership of Dr. Vanita Ahuja, our National Governing Council member, we are holding a webinar immediately after the Indore conference. So thank you, Dr. Vanita, for organizing this webinar. And the theme is also very good because it is close to my heart. It's about pain medicine, and you have kept the topic on cancer pain. And I'm so thankful to all the faculty because I firmly believe that the faculty makes the program successful. So I'm thankful to Dr. Palta sir. Namaste, Dr. Palta, Dr. Richa Sroha, Dr. Babita Gai, Dr. Gauri Mitra, Dr. Rajesh Mahajan, Dr. Dimbri, Dr. Dheeraj, Dr. Nimisha, Dr. Thapa, Dr. Jitendra Makkad, Dr. Ankita Basin, and Dr. Parveen Talwar. So I'm very sure that it will be a good and fruitful, it will be a good and fruitful webinar, and we are lined up for such academic activities at regular intervals. Our RSA GOCP editorial fellowship for the year 26-27 have also been launched. If you want to contribute to the newsletter, the RSA Times is there, and the preparations for RSA Con 2027 at Lucknow have started. So please save the dates. It's the first weekend of April 2027. I again extend my best wishes to Chandigarh branch for conducting this webinar. Thank you very much.
Thank you, sir, for your such kind words and encouraging us. Now I invite Dr. Vishal to please, Secretary RSA, to please speak a few words.
Good evening, everyone. It is my pleasure to address the August gathering here. And I also would like to congratulate Team Chandigarh for holding and crafting this webinar. We have with us the big stalwarts of pain medicine to give insights into the cancer pain management and the role of buprenorphine, the panel discussion and pros and cons session. And once again, I would like to thank Dr. Vanita Ahuja, madam, to organize this webinar on such a short notice, ma'am. Thank you very much. And it's all yours, ma'am. Dr. Vanita, ma'am, please.
Thank
Over
you,
to
sir.
you, Dr. Vanita.
Yeah, thank you, sir. Now I would like to invite our chairpersons for this session, which is a pro and con session. Dr. Sanjeev Palta, sir. He's head of the department.
Good evening, Vanita ji.
Sir, good evening. You have been the pillar of, support and guiding light for all of us, sir. So I welcome Dr. Sanjeev Palta, sir. Dr. Babita Ghai, she's from PGIMR Chandigarh. Madam is working a lot in management.
Good evening, everybody.
Good evening, ma'am. Thank you, Dr. Palta, sir, Babita ma'am, for joining us. Thank you so much. I would like to also invite Dr. Dheeraj Kapoor, who is a faculty here in GFCA Chandigarh, and he's also.
Good evening, everybody.
Good evening. Thank you, Dr. Dheeraj, for joining us. And with your kind permission, we would like to start the first session, which is a pro and con session. And the topic is role of opioid patches in acute post-operative pain. Is it use or it is misuse? So I would request the chairpersons to, they invite the first speaker who will be speaking on the pro session. And I would also like to, allow the Dr. Ankita to have her presentation for presentation.
Babita ji, please introduce the speaker.
हेलो
बबीता जी इंट्रोड्यूस कर दो स्पीकर को जी.
एक मिनट सर
जाना है आप नहीं मैंने आप जाओ
हेलो हाँ जी it is our pleasure first of all I will like to thank Dr. Naveen Malhotra, Dr. Vishal as well as Dr. Vanita to hold this webinar in such a short notice. And I would like to now invite Dr. Ankita Bhasin, who is very dear student of ours, and she is an assistant professor at GMCH Chandigarh. She'll be speaking on the role of opioid patches in acute post-operative pain, and whether it is use or misuse. So Ankita is going to speak about the pro that it has been properly used. So over to you, Ankita.
Very good evening, everyone. Thank you so much. I thank you everyone for the opportunity that I have today, and I hope I'm able to able to defend myself in this very tricky pro and con session. Thank you so much. I hope I'm audible and my screen is visible.
Yes, Dr. Ankita,
Yes,
you're
please.
audible,
Go ahead.
and you have 7 minutes to prove your point, please.
Thank you so much. So today I'm speaking in a pro-con session for opioid patches for acute pain. Now, before we start with this session, because we have a lot of postgraduate students here, so I would like to tell that whenever we talk about opioid patches, we are mainly talking about the transdermal route. So transdermal route in which a patch is usually attached on the skin, and from the stratum corneum, the drug gets absorbed into the local capillaries and then into the systemic circulation. So usually there are just two opioids that are used via transdermal route, that is fentanyl and buprenorphine. So there are two types of transdermal patches, which are reservoir patches and matrix patches. So in the reservoir patches, the drug is stored in a reservoir and a membrane controls the release of the drug. And another one is the matrix patch, in which the drug is in form of a polymer matrix in an adhesive, and it is gradually and slowly released into the system. So this is what the difference between a sublingual or a IV pharmacokinetic and a transdermal buprenorphine or a transdermal drug. So as you can see in the graph, the transdermal drug slowly and steadily increase and comes into the system, and then there is a constant plasma peak. And whenever the patch is removed, there is a slow decrease of the drug. So hence it slowly increases and it slowly decreases, and there is no immediate on and off switch in a transdermal system. While if you can see the graph of the sublingual system, then there is a peak, crest, and trough-like graph. Whenever the drug is taken, IV or sublingual, there is a peak, crest, immediate release, and then there is a trough. That means the action is the plasma concentration decrease. Again, it increases and it decreases. So it's more like a peak, crest, and trough, while the transdermal is very smooth but slow. So as we have already discussed, not all drugs can be available via transdermal system. Only lipid-soluble drugs with low molecular weight and high potency drugs can only be used, which are fentanyl and buprenorphine. So now, before I start with this pro session, what are the drug characteristics or which are desirable, and what is the route which is desirable for acute pain? Just very simple for acute pain, perioperative pain management, we like drugs which have rapid onset, rapid offset, and these are easily titratable. That is, which have simple on and off switch. If there is an overdose, we just switch off the drug. If the patient needs more drug, we give more drug, and there should be a sudden action, and we should be able to titrate. But this is good for ambulatory surgeries or minor surgeries. But when we talk about major surgeries, in which we are expecting that there is a continuous pain and the pain is going to stay for long, then we are looking for some background or basal analgesia so that there is a continuous basal analgesia and there is no breakthrough in the pain. And that's where the role of transdermal mucosal system comes in. So there are 4 questions that we need to answer. The first question is, can the transdermal route be used for acute pain management? Again, this is the most debatable question because it is slow and steady and not fast on and off. And next, is there any evidence of use of transdermal opioids? And does buprenorphine have advantages over other opioids? We are specifically talking about buprenorphine here because buprenorphine is more commonly used as compared to transdermal fentanyl for perioperative use. And the last one is, should the transdermal opioids be used in all patients undergoing surgery? So let's go through these questions one by one. So what is the advantage of a transdermal system which we can use in our favor in perioperative period? So there is a gradual, stable background infusion, no crest and trough. Whenever there is a crest, the action is immediate and strong, but there are also more side effects, more nausea, constipation, pruritus as compared to when a drug is transdermally introduced in the same form. Also, now in the perioperative periods, patient may not be able to take oral drugs, or patient may not be, they may be sedated or may not be good enough to take a sublingual drug. But for a transdermal patch, it can be applied and it is independent of the patient compliance. We just have to apply it on the skin and the drug will have its action, and it is not dependent on the patient compliance. And another important thing is that the plasma concentration stays the same independent of age. And since it's a patch and there are no infusion pumps attached, so the patient can ambulate. So again, the same graph, that it's a slow and steady concentration, no peak and no crest and trough. So there are lesser side effects. These are the 2 studies which show that which is comparing the transdermal pharmacokinetics between elderly and young patients. And as you can see in the first graph, the availability and the pharmacokinetics is similar in both elderly and young patients. And the second graph is showing the transdermal fentanyl pharmacokinetics in a pediatric patient, which is again same. And hence, the delivery is independent of age. Now the next question. Does buprenorphine have special advantage? Now, buprenorphine came into picture in 1970s because it's a partial agonist. So we wanted some desirable actions of opioids, like it should be a potent analgesic, but there should be no undesirable effects. And buprenorphine totally fits into the picture. It's a partial mu agonist, but it's a kappa antagonist, delta opioid antagonist. Hence, it has less euphoric effect, less sedation, less nausea, vomiting, less constipation, but a very potent analgesic. And it has another effect on ORL1 receptors, which gives added effect on the analgesia. Moreover, buprenorphine is, because of its less euphoric effects, it is not very much likable by the people who abuse opioids, and hence it has low abuse potential. And as you can see these graphs from the Miller's anesthesia, that there is low risk of respiratory depression because it has a ceiling effect. As you can see in the fentanyl graph, as the dose of fentanyl increases, there is apnea from the minute ventilation gradually decreases, and then there is apnea reaches to 0. While for buprenorphine, there is a ceiling effect at some dose, and hence there is decreased risk of respiratory depression as compared to fentanyl. Also, there is a big question that buprenorphine, since it's a partial agonist, so it can antagonize the action of full mu agonist because it is also more potent. But that is true only at higher doses, that is doses more than 16 mg. And analgesic doses more than 16 mg per day are rarely required when we use buprenorphine. So when we use low dose basal buprenorphine and when we give full agonist with it for rescue analgesia, the given analgesic has an additive or synergistic effect. Now, there is another recent systematic review and meta-analysis, which was published in Region Anesthesia and Pain Medicine. which compared the use of buprenorphine via all routes versus full agonist action. And it showed that the average pain scores were lesser in buprenorphine group as compared to the other opioid groups, although the heterogeneity was high. And the rescue analgesic requirement was also lower in buprenorphine group as compared to other opioid groups. So buprenorphine is definitely a good potent analgesics which can be used in perioperative period. Now, do we have evidence of use of transdermal buprenorphine in postoperative pain management? So we have another systematic review which was published in 2020, and we have more studies after 2020 also, in which the buprenorphine was used for postoperative pain management. So in this meta-analysis, there were 9 studies. So the surgical procedures in which the transdermal buprenorphine was used were spine surgeries, major elective abdominal surgeries, hysterectomies, myomectomies, hip surgeries, etc. In all these studies, the buprenorphine was started 6 to 48 hours before surgery so that the patient has a stable peak plasma concentration at 12 to 24 hours post-operatively. And it had varied doses, and it was maintained, the patch was maintained for 1 to 7 days after the procedure. So as you can see in systematic review and meta-analysis, there are only a few types of surgeries in which transdermal buprenorphine patch or opioid patches can be used. These are those major surgeries in which we are anticipating moderate to severe pain, and that pain is going to stay for up to 7 days. So there is a predictable, prolonged trajectory of the pain. So there's another evidence, although it's not in the perioperative period, but where buprenorphine was used for pain management in older patients with multiple rib fractures. Again, the pain trajectory for rib fractures can extend from 7 days to up to weeks. So coming up and summarizing all 4 questions. The first question, can transdermal drug delivery route be used for acute pain management? The answer is yes, as a continuous background infusion, but a part of multimodal analgesia to avoid breakthrough pain and reduce rescue analgesia opioid requirement. Second question, any evidence of use of transdermal opioids in acute postoperative pain? Yes, as discussed, and transdermal buprenorphine has been used more than transdermal fentanyl. Does buprenorphine have any advantages over the other opioids? Yes, selectively retain the desirable actions while shedding the undesirable effects. And should the transdermal opioids be used in all patients? No, it should only be used in major surgeries where we are predicting prolonged pain trajectories. Now, before we end, can transdermal route have a rapid on-off switch? Well, the answer is iontophoresis, which is again a drug delivery technique in which electric current is used to deliver the drug as fast as possible. And as soon as the electric current is switched off, the drug action stops. So ionosis was actually a iontophoresis transdermal patch system for fentanyl, which was there in the market for some time, but which was again taken off because of some technical issues, and the research is still going on. Now, ionosis had serum fentanyl concentration similar to the IV infusion. And iontophoresis is the answer for the rapid on-off switch that we want in the transdermal route. Now, the quest for the ideal transdermal PCA route still continues. And I think that when iontophoretic patches are made for buprenorphine or fentanyl, then this debate will actually end, that whether we should use or should not use, because then we will have the ideal transdermal PCA that we want for the patient. To summarize, transdermal opioid patches can be used for acute pain management as a background or basal analgesia of patients undergoing surgery with anticipated moderate to severe pain with a predictable prolonged pain trajectory, and or in patients with a higher preoperative pain scores or chronic pain. Thank you.
Thank you, Dr. Ankita, for your wonderful and insightful pro session on the use of transdermal opioids in acute postoperative pain.
Thank you.
You did presented the evidence also. So let's see what our next speaker has to say against it. So over to the next chairperson for introducing our next speaker, and then we can have the rebuttal at the end of the next
Dheeraj, I
speaker.
request you to please introduce the next speaker. Dr. Dheeraj,
Yes, sir.
please introduce the next speaker.
The next speaker. So there is some audio.
Dr. Palta, may I introduce?
Ma'am, आप introduce कर दो जी, please. Dr.
Okay,
Babita,
so
हाँ जी,
our
please
next
introduce.
speaker is Dr. Praveen Talwar, who is the additional professor at AIIMS Rishikesh and is also the core faculty member of the pain fellowship DM pain program there. So Dr. Praveen will speak against the use of transdermal patches, opioid patches in acute postoperative pain. Over to you, Dr. Praveen.
Thank you, ma'am. Good evening, everybody. I first of all would like to thank the RSA Chandigarh branch and the national president, Dr. Naveen Malhotra sir, Vishal Singla sir, for giving me this opportunity. And I would also like to thank Dr. Vanita Ahuja ma'am for giving me this opportunity to my role in the pro-con session. Is my slide is visible, ma'am?
Yes, Dr. Praveen, your slides are visible and you are audible.
Yes, ma'am. I'll be speaking on role of opioid patches in acute postoperative pain management, its use or misuse. I'll be speaking on the con perspective. There is a rising interest in transdermal opioid patches because, as already said, it is a convenient opioid delivery system and promising drug delivery route with high patient compliance, and it provides a painless drug delivery and long drug retention time and stable blood concentration. But their role in acute pain is controversial. And I'd like to critically evaluate opioid patch use in the acute postoperative pain and highlight the risk and limitations and misuse potential in this presentation. The pharmacological basis of opioid patches that advises against the use is like it is the opioid patches are designed for chronic pain, not in the acute pain setting. Especially the fentanyl patch, it is a US FDA is used for only chronic pain, and it is for a patient who are already opioid tolerant. The first time user for the fentanyl patch should have an adequate prior exposure to opioids. In one study, longitudinal analysis on the safety of fentanyl initiation done by Friesen et al. In 2016, and they have identified 11,000 opioid prescription initiation of fentanyl, and they found 70.1% of the patient had inadequate prior opioid exposure to warrant initiation of these opioid patches, like especially the fentanyl patch. And most patients included were of age of 65 age and older, which are highest risk for opioid side effects like respiratory depression. And 26.3% of the prescription were fully opioid naive patients, which represents a prescribing error and systemic failure. And it is a Schedule 2 opioid agonist, and it has a potential for abuse and could lead to serious respiratory depression. It is not indicated for acute postoperative pain due to the risk of serious life-threatening respiratory depression at times death, which is mentioned as an important warning by the drug manufacturer themselves. The only patient who have used the equivalent of 60 milligram morphine per day for at least 1 week should be prescribed 20 microgram per hour fentanyl. Failure to adhere to these recommendations were associated with serious adverse effects like depression of the central nervous system, hypotension, bradycardia, respiratory depression, and deaths. And there are numerous case reports of deaths associated with transdermal fentanyl, especially associated with inadequate opioid exposure before the initiation of fentanyl patches. A Health Canada review found 11.5% of the 52 fentanyl-related deaths were associated with the fentanyl patch initiation. And Canada Vigilance Adverse Reaction Online Database also found 284 deaths involving fentanyl patches. And it is the patches are unsuitable for acute postoperative pain setting because of the slow onset and prolonged duration. The kinetic absorption of opioid are unpredictable, and the onset of action takes several hours, at least 24 hours. Mainly it depends upon the body temperature, the previous dosing of the opioid, factors such as site of application, and the patient's hemodynamic and general condition of the patients. And even after patch removal, the absorption continues unpredictably for several hours. And due to this slow onset of action, patients are asked to apply these patches one day prior, which is not justified. And for other the factors like cutaneous blood flow at the site of patch influences the rate of absorption. Like if the patient is having fever, use of warming blanket during the surgery, humidity, and vasodilating due to use of regional anesthesia. And all these conditions hastens the rate of overall systemic drug absorption, leading to elevated levels of fentanyl, and that could lead to respiratory depression even in patients who are opioid tolerant. Therefore, these patches are unsuitable for acute postoperative pain and especially daycare procedure where analgesia can be managed with multimodal approaches. Again, they are not suitable because of delayed onset. They takes 24 takes hours, and they are poor match for immediate postoperative pain needs. And like the most important risks associated with these are CNS depression and respiratory depression and prolonged accumulation leading to long half-life and difficult to titrate in the acute pain settings. And because once applied, it is difficult to adjust the dose and lack of rapid reversibility compared to IV opioids. So, and there is again potential for misuse and diversion, especially they have high abuse potential, and the patches can be misused outside hospital settings. And they again are associated with all the side effects like nausea, vomiting, constipation, sedation. Especially the risk is increased in who are opioid naive postoperative patients. And they are associated with delayed awakening, impaired mobilization, and they have a negative impact on ERAS protocols. And most of the clinical guidelines recommend against the use of opioid patches for acute pain. And these patches should be reserved for chronic cancer and palliative pains. The International Multidisciplinary Consensus Statement on the Prevention of Opioid-Related Harm in Adults again, many and along with other clinical guidelines, avoids long-acting opioids and this transdermal patches formulation in the acute postoperative pain settings. Again, there are ethical issues like patient safety compromised by unpredictable absorption and risk of accidental exposure to children and caregivers. And there are many opioid alternative alternative therapies are available to opioid patches like multimodal analgesia in the form of NSAIDs, acetaminophen, and regional blocks. And short-acting drugs, opioids, can be used when necessary. So my summary of this con argument is unsuitable pharmacokinetics. The safety risk outweighs the benefits, and better alternatives are available. So opioid patches in acute postoperative pain is a misuse. It's not a use. And there is a need for evidence-based and patient-centered strategies. Thank you.
Thank you, Dr. Praveen. Yeah. Now I would request the chairpersons to please start the rebuttal or.
Yeah, Dr. Vanita, what I can see, if we compare what Dr. Praveen told about is the transdermal fentanyl patches, and Dr. Ankita was emphasizing on transdermal buprenorphine. So if you see the evidence that is in favor of the transdermal buprenorphine because of the side effects which are less compared to the fentanyl, which is a very potent opioid. And what we can see is the timings, the timing when to apply the patch, and then the type of surgery, and then what type of surgery and the pain what is the duration of the pain post-operative? That matters most. Though there is very less evidence maybe in favor of the transdermal fentanyl patches, because it is not recommended basically for the acute post-operative pain. But the evidence, the large evidence meta-analysis also done, which is shown by Dr. Ankita, that yes, buprenorphine can be used. But again, as Dr. Parveen have stated very clearly, that it depends. Transdermal patches, the amount of, that is the drug, that depends on the temperature of the patient also, how the delivery system is affected by many, many aspects. Now, during the surgery, how much is, and there is evidence that all these patches, especially buprenorphine too, it should be used not as a sole opioid in the post-operative, but as an additive if it is to be used. And if you talk about transdermal fentanyl, then of course it should be used, if at all, in a very small subset of patient, because of the side effect, the most common side effect, that is the respiratory depression. So what I can infer out of this, that buprenorphine, yes, it can be used, but with caution. Fentanyl in a very small subset of patient, depending on the type of surgery, and maybe more evidence is required to advocate this fentanyl for that. Dr. Palta.
Yeah, I'm not an authority on pain. I'm just here to listen to everybody. Babita, you must contribute here.
Yes. So, having heard pros and cons, what we want to first I want to highlight is that the fentanyl patch, especially the fentanyl patch, is not FDA approved in acute postoperative pain. In fact, it is contraindicated in acute postoperative pain. And as Dheeraj has summarized, that the evidence of only the buprenorphine patch is there in acute postoperative pain. That too, the evidence is less and sparse. So we have to realize that in acute postoperative pain, the fentanyl patch is actually contraindicated. Buprenorphine patch can be used, or more evidence is required to use in the acute postoperative pain. In select of surgeries where the duration is expected long for the pain, and there is more moderate to severe postoperative pain is there. Having said that, we have lot of multimodal analgesia, which is really less side effect profile, and henceforth the my take is that opioid patches in acute postoperative pain is still to see the evidence, and fentanyl definitely not.
I think, Babita, you have already answered Dr. Vishal's question also, which is there in the chats. And I mean, all the participants, you are encouraged to ask the questions. All the doyens and pioneers in pain management are sitting over here.
I am Dr. Rajesh Mahajan. I just want to add that the fentanyl patch is abuse potential, and a journal in forensic medicine has reported about 630 deaths till date, which are attributable to fentanyl patch, and it has a addictive potential. So it should be used in a very cautious way in acute postoperative pain. Patients can develop addiction by consuming the patches. Patient can take them orally.
That's a good observation, Rajesh.
So we have a lot of patches in our setup. We are running a palliative care center also in GMC Jammu. We have a 10-bedded ward, but we just avoid fentanyl patches. A lot of patches where we don't give in acute postoperative pain. We just use only in palliative care and cancer patients where they are required.
Dheeraj, what is your experience in this?
Sir, we use sometimes this buprenorphine, not fentanyl. Never we have used these patches for the postoperative pain management. Yes, for buprenorphine may be used, especially in a selective subset of patients at present. Those who are taking opioids pre-operatively for one or the other reasons, mainly for chronic pain, maybe neuropathic pain, non-cancer pain, we can use. But again, the problem which comes with us is that what is the dose to be given? Because buprenorphine comes in different dose, 5, 10, 20 mics per hour. Now, what is the optimal dose? So we generally apply in the lowest dose, maybe 5 or 10 mics, but the pain scores, then we have to titrate. It's very difficult to titrate that with buprenorphine. That is one problem which comes with us. So that's why we are using as a multimodal analgesia this buprenorphine. We are using as a background. We can say a background of 10 or 20 depending on the opioid requirement in that particular patient. Like the patient is taking the morphines, then we have to calculate the morphine equivalent, or if the patient is taking any other opioid. So sometimes these patients are on buprenorphine preoperative. So we can use that buprenorphine patch 48 hours before the surgery and to continue for 6 or 7 days, maybe up to that's a 7-day cycle. So we can, but the problem which comes is that only buprenorphine to be used as for the post-operative management, a big no. We can modulate it, we can enhance it with other particular modalities like the regional blocks. And yes, then it can be helpful, but titration is still very difficult in these patients as per my experience.
I just wanted to add a point. Sir, I wanted. I went detailed through the conversion of buprenorphine and fentanyl. It is nearly same. If you give a 5 microgram patch, and that is equivalent to approximately to the 5 microgram fentanyl. So if you can convert fentanyl to the morphine equivalents, so same holds true for the buprenorphine patch.
Yeah, but the side effects of buprenorphine, because it's a partial agonist to respiratory.
It's not so good.
So that's why fentanyl, that is a big fear with fentanyl patches. They are being used in even cancer pain, but again, the threshold, the pain thresholds are different compared to what these patients who are posted for the surgery, because they are not exposed to the opioids before. And suddenly
yes, you are right. You are right in that.
Especially fentanyl.
Yeah, it's a very high dose. Even 12.5 microgram is equivalent to a 45 milligram morphine per day. But about 2.5 to 3 times is the equivalence with the morphine. So it is a high dose of morphine per day. If you fentanyl patch is not safe.
Thank you, Rajesh. I think Babita, we will be running out of time. आप just summarize करो और conclude कर दो आप किस तरफ?
Sir.
So,
Babita ji.
So I would say that I am against the use of opioid patches in acute postoperative pain for the reason that the pain decreases as the time progresses. However, the delivery of the drug remains the same with these patches. Henceforth, it is very difficult to titrate. So my take is that I would not like to use patches, only subset of patients which are there, if they are already on buprenorphine patches, then we can think of using it in the postoperative period.
Thank you, Babita ji. There is a message by Dr. N. Raghunandan that he has an experience of his own orthopedic surgeon using buprenorphine instead of post-operative epidural pain management, but he has not written clearly the good or bad experience. Anyhow, Dr. Raghunandan, you please write over here. We are thankful to Dr. Naveen, Dr. Vishal, and Dr. Vanita, and allow me to conclude this session so that you can start the next in time. Thank you very much. Thank you, Babita ji. Thank you,
Thank you very much.
Thank you.
Thank you. Okay.
Thank you. I would like to thank our esteemed chairpersons and the speakers on, holding up this session in such a, nice way. And we are very thankful to our chairpersons and the speakers. So I think Madam and Sir has put up everything so clearly in front of us that patches need to be explored further. They are not the, have the evidence is currently not in favor. So we are very glad to have this. So now moving on to the our next session, which is on the panel discussion. I think I have my esteemed chairpersons for the next session. I would like to invite our chairpersons, Dr. Naveen Malhotra, sir. He's the president of RSA, and he also has he's the director of the ARS Pain Management Center. Welcome, sir. I would like to welcome Dr. Deepak Thapa, sir. Sir is holding he's a very eminent pain physician, and he's working with us in GMC at Chandigarh. I would like to invite Dr. Jitendra Kaur Makkar. She's working in pain management in PGIM at Chandigarh. Welcome, Dr. Jitendra. And Dr. Rajesh Mahajan, he's working in pain and palliative care at GMC, Jammu. So I would like to invite and welcome you all. So we would like to start.
Madam, you are also kindly requested to welcome.
Is there?
Please welcome the panel discussion panelists as well, ma'am.
So,
Yes. I'm just trying to, share my slides with the. So is my slides there on the screen right now or no?
Yes, ma'am, it's visible, panel discussion.
Yes, it is visible. So I'll just put it on the presenter mode now. And right. So,
Dr. Vanita?
yes, sir. Very good evening, Dr. Jitendra. We are very happy to have our esteemed panelist. And now you can invite, I will request the chairpersons to please invite our speakers. I am the moderator for the panel discussion. I would request one of the chairpersons can invite the speakers.
Dr. Jitendra, ma'am, can you please do the favors, ma'am? Dr. Jitendra Kaur Makkar, please, ma'am.
Okay, then I think I will invite.
Okay, ma'am,
First,
please.
Dr. Deemri is with us. He is a professor and head of radiation oncology at GMC at Chandigarh. And he is he works very keenly on pain and palliative care with us. And he has a lot of, books and publications to its credit. So welcome, Dr. Deemri. You're most welcome here. Please. He's consented to be with us. He's a non-anesthesiologist, and he will give us the insight into the oncology management. So welcome, Dr. Deemri.
Thank you, Dr. Vanita.
Yeah. Next is a dear friend, Dr. Richa Sarowa. She's professor in Department of Anesthesia and Intensive Care, and she has keen interest in regional anesthesia, focus, critical care, and obstetric anesthesia. I welcome you, Dr. Richa Sarowa.
Very good evening to all. Thank you, Dr. Vanita, for kind introduction. Thank you very much.
Right. Our next panelist is Dr. Nimisha Verma. She's professor in Pain and Palliative Care Division at Department of Anesthesia, Varanasi, very dear friend, and she has a lot of work in cancer pain, and she has she's done a lot of cases in celiac plexus and ultrasound guided. Welcome you, Dr. Nimisha Verma.
Thank you so much, madam. It's a pleasure to be here in the gathering today.
And now we have Dr. Lalita Gauri Mitra, ma'am, and she is professor and head in Department of Anesthesia in Pain Management and Critical Care Medicine in Homi Bhabha Cancer Hospital and Research Center. Madam has a very expertise in onco-anesthesia and solid organ transplant, and she works a lot in the critical care at Homi Bhabha. So we welcome you, ma'am. So we all know that cancer pain management is not that easy. It's not a cup of tea for everybody. And the type of pain that is also very different in different type of patients, especially when we have a mix of nociceptive and neuropathic pain. And cancer pain doesn't remain the same. It is very variable. Sometimes whenever there's a curative phase, it might reduce. If there's a recurrence, it increases. If there is if it falls into a place where the curability of the cancer is not possible, then of course there's a mix of pain, and the patient also struggles through the pain and the symptoms. So that is the crux of our panel discussion. And we are aware of the WHO step ladder analgesic ladder, which initially was of 3 steps, but now it is of 4 steps. And in that we have the interventional pain step, which is the 4th step. And it is not that we have to follow it by one, but we can straight away go to the step 4 if the patient is in severe pain, where step 1 says about in the mild pain, that it talks about the non-opioid with the adjuvant. Then it is for the moderate pain is your opioids, which are the weak opioids with adjuvants. Then in severe pain, we have the strong opioids and with the adjuvants that we can use. And 4th is intervention. This is just to start with a brief summary. And there is one more method of, managing a custom-made or a tailor-made management, which talks about the different type of trolley, like multimodal trolley approach, where you can use combine the other, non-pharmacological methods also along with the, other WHO analgesic ladder pattern. And now there's an advent of these cannabinoids and other, which is we talk about the total pain when we talk about psychological support, relaxing therapies, physiotherapy. So all these have also become a very important part of the total pain management of this cancer patients. Now coming to the case scenario that we will be, discussing, we put a a simple case for, so to make the talk a little more, thought-provoking. We have a 55-year-old male which comes to the PSC clinic for carcinoma head of pancreas. Now the patient does not have any comorbidities, but he does complain of an upper abdominal pain distension, which progressively increases, having jaundice, itching, reduced appetite, and weight. Now, patient complains of clay-colored stools and has having pruritus since 1 month. He is a chronic smoker for the past, 20 years, and he is also a chronic alcoholic from the past 20 years. He's a 10th pass as security guard, and when he presents to the PSC clinic, he has a heart rate of 100 per minute and a blood pressure of 100/60, and his by and large respiratory functions are by and large acceptable. So now I would like to go through the investigations, which clearly show that there's a rise in the bilirubin, and there is a borderline albumin, and the CRP is, is okay, but his markers, cancer markers are raised. The ultrasound shows that there's a marked dilatation of the pancreatic duct with a mass effect, and CT shows a mass which is, 3 into 4 centimeter over the head of the pancreas. So the endoscopy also reveals that there is a solid growth in the head of the pancreas. Now, this type of patient usually presents certain challenges, which we will be discussing in the relevant talk. Now, my first question is to Dr. Richa, that how will you evaluate this patient for a Whipple procedure? Because patient came with set of investigations, but now how we will systematically go through evaluation of this patient, because the surgeon wants to do a Whipple's procedure or a pancreaticoduodenectomy. So over to Dr. Richa Sarova.
So thank you, Dr. Vanita Ahuja. The thing is that these patients, they need to go a thorough preoperative evaluation, because even if the patient has not presented with much complaints, there is a lot of systemic involvement. So in a pre-anesthetic evaluation, one must assess the extent of the systemic involvement. And one should try to identify the reversible causes or abnormalities before the surgery and correct them if it is, possible. It is also important to predict the perioperative risk and optimize the organ functions in these patients, and plan the intraoperative monitoring and vascular access, blood products, and postoperative ICU care in preemptively, actually. And since these patients, they are very, very apprehensive, it is always important to have a preoperative counseling to allay the anxiety of these patients, and talk to them, meet them 1 day or 2 days prior to the surgery. And of course, this patient is also a smoker and has been alcoholic, so it is mandatory to see that whether they have the cessation of smoking, alcohol has taken place. We have to do that. And of course, because of the malignancy, most of the patients, they have preoperative anemia and their nutritional status is not good. So it is important to go through the entire history and examination, which focuses on the presenting illness, the constitutional status, the other comorbidities, and any prior interventions that has taken place in this patient. And as far as general physical examination is concerned, all the systems, they must be evaluated, pardon? So they must be evaluated, and with a special, mention to the renal system, and a special mention to the respiratory examination and abdominal examination. And then, as far as lab investigations are concerned, going by the, lab profile, one must order all the investigations, because these as I said, these patients are prone to preoperative anemias, they are prone to nutritional deficits. So, and then because of the liver involvement, they are prone to coagulopathy also. And because of the coagulopathy, they may have underlying coagulation disorders, vitamin K malabsorption is pretty common, and they need to undergo all the liver function tests and other tests. And these days they say that one must predict the cardiac risk in this. Even the pre-operative pro-BNP levels, they have been suggested, and one must go the standard, scores. They must be done in these patients to see the perioperative and post-operative risk and plan accordingly.
So, Dr. Richa, do you think that the abdominal surgeries that we get, done in our operating rooms, like a laparotomy or something, besides, duration of surgery, besides, how are these subset of patients who are having malignancy, different from the other set of patients?
One is that the patients of malignancy, if we talk about this Whipple's procedure, surgery itself, you said it's a prolonged surgery, but more than that, itself has 3 anastomosis. And these patients, all said and done, however good the surgery is, they are prone to complications in intraoperative and postoperative period. Then these patients, mostly they will present with obstructive jaundice. They have high bilirubin levels, and high bilirubin levels, after a certain extent, they have direct cardiodepressant effects, they have direct renal effects. So all these things, they have to be taken care of. Then they have underlying, again, they can have coagulopathy, they have severe malnutrition, cachexia, the serum albumin levels may be low, so you have to titrate your induction agents, you have to titrate your other drugs accordingly. There is increased risk of renal dysfunction and sepsis in these patients. These patients, they may have pancreatic endocrine dysfunction. Is very common. Intraoperatively, preoperatively, and even postoperatively, they can have diabetes. So one needs to plan that if they need postoperative, this therapy, you have to plan it preoperatively. They may have, there is a need of invasive monitoring, and again, according to the scoring system and according to the extent of the malignancy, you have to make a prior post-operative plan, whether you need to shift them to the ICU. Now, these patients, of course, with the malignancy, they have greater fluid shifts, blood loss, hypothermia, longer surgery duration, post-operative complications we have discussed. And on the top of it, when we are discussing about all this, as anesthesiologists, we also talk about, relieving the pain of these patients. So with the coagulopathies, because we definitely, in these patients, we need to have some good post-operative pain modalities. So we definitely need epidural anesthesia. But in case it is not possible, one has to think of the PCA, and ERAS protocol and multidisciplinary approach have to be kept in mind for these patients.
Right. Thank you so much, for putting it all, together in just few minutes. It's a really, so I'm sure the postgraduate students are being benefited with, this type of the description which Dr. Richa has said, that you need to be very, prepared for these type of patients. So when you talk about the perioperative management, which you have, beautifully summarized, and the plan has also been mentioned by Dr. Richa. So I would like to just put a question to Dr. Lalita Gauri Mitra, ma'am, that if this patient, is get shifted to the ICU, and it has been very well managed in the, operating room. Now, how will you, manage this patient in your intensive care unit?
Thank you so much, Dr. Vanita, and thank you for this kind invite as well. I think the first thing in the immediate post-op management of this subset of patient, we should prioritize hemodynamic stability, rigorous surgical site monitoring, look at the metabolic regulation, and have an aggressive pain control to manage any life-threatening anastomotic, because they all prevent life-threatening anastomotic leaks or failures. So when we look at hemodynamic and fluid management, we have to look at our goal-directed fluid therapy. So maintain a neutral fluid balance, because throughout the day, there have been ups and downs, and they usually come a little positive to us to the ICU. So we have to ensure that we try and maintain some form of a euvolumia. We do not overload these patients, and that is basically to avoid overloading our tissue. So that's the first thing. The second thing is, we have to have, we are very scared of using, norepinephrine or low-dose vasopressors, and so we should use a low-dose vasopressor if required, and, instead of really overloading these patients. So should have a low threshold for that, and obviously, if required, and we see our patients not doing well, get in an invasive line a little bit earlier, and monitoring the urine output is very, very, very important. Next is when you look at metabolic and status, you must maintain euglycemic management, and which we typically say is between 140, 180 milligram per deciliter, and look out for any brittle diabetes depending upon how much of the pancreas really has been resected. It goes without saying that pain and is very, very important. Even though it is an ICU, we should be equally responsible for what kind of pain management we give this patient. So if these patients, and at least in our setup, all these patients have a thoracic epidural catheter, but those institutes that do not do it can use a continuous tap block. And if the patient is on a ventilator, we might have the luxury of giving them some fentanyl, but that should be weaned off really early so that we can target an early extubation in this subset of patients. Next is nutrition. Nutrition will probably come back, maybe not really in the immediately 8 hours. So what I say, the immediate post-op period, but as they say, as a part of ERAS protocol, one should get them. The nutritionist should start as early as possible, especially if you have a feeding J in place. So do start that early, ambulate them early in the next day. And low molecular weight definitely should be started between 6 to 12 hours post-surgical in the subset of patients, because we know they have a high risk for DVT. So if the surgeons are not very comfortable for it to start it at 6 hours, at least ensure that they have a sequential compression device or and they have your TED stockings in place. Next thing that we always say that it's the surgeon should be doing it, but we should be equally doing it as looking at the abdominal girth, looking at the size of the abdomen, what the abdominal drain is, if there is any blood draining out of any of the catheters that have been placed. So that part is equally important for us as well. And obviously we look at if there's delayed gastric emptying and we are seeing more than, we start seeing a high volume gastric loss, and ensure that, because that's going to lead to metabolic alkalosis and hypokalemia. So if we are looking at that in our ABGs, make sure that that is corrected as well. So I think that takes care of the first 6 to 12 hours post-operative of this subset of patients.
Right. Thank you so much. So I would like to ask Dr. Kisle that since these type of patients, when they present early to your department, like what is the plan of treatment from your side in these patients in the early presentations?
Thank you, Dr. Vanita. So first of all, it's important to discuss such patients in an MDT comprising of a surgical, a medical, and a radiation oncologist. And then we need to decide whether this patient, and in fact, there is a certain criteria which we follow where we decide whether this patient has got a resectable disease or a potentially resectable disease or maybe a locally advanced cancer. So most patients of cancer of the head of the pancreas, these patients, they end up receiving neoadjuvant chemotherapy or preoperative chemotherapy followed by surgery, Whipple's procedure. Those patients who have a locally advanced disease, non-metastatic disease, but inoperable at presentation, they will also receive neoadjuvant chemotherapy, and in spite of that, even if it still remains unresectable, then these patients will receive chemoradiation. This particular patient, has got a high level of CA 19.9, which is like 200 plus, and also has obstructive jaundice. So with such high levels of CA 19.9, the chances of occult metastasis is high. Which may actually not be picked up on a CT scan or even on a PET scan. So this particular patient should receive preoperative chemotherapy and also a pre-surgical biliary drainage, because otherwise because with such high bilirubin levels, you cannot give chemotherapy. A very small patient which is these patients, a small lesion which is eminently resectable can also undergo upfront surgery followed by adjuvant chemotherapy. So this is going to be the approach from our side, from the oncology side.
So what I can infer from that is that initial treatment is very different from when the patient has a recurrence or a metastasis when they present to you. So how is your initial treatment different from when they present to you with a recurrence or a metastatic malignancy of the pancreas, or how do you manage those type of?
So the management of a recurrent or a metastatic head of pancreas is very different. and it's more of a palliative, more of in a palliative setting. But now you have a lot of other, like earlier only conventional chemotherapy was available and the prognosis used to be really poor. But now there are certain targeted therapies and immunotherapies, checkpoint inhibitors, which are available for management. So initially, like if we have that biopsy specimen with us, so we do certain mutation analysis, mutation test we do, which generally includes BRCA 1 and 2. We do an MSI or MMR, and there are certain other basically it's a part of NGS or generation sequences. And after having done all these investigations, depending upon like what is positive, because in some cases it may be positive, in some cases it will not be positive. So if all the mutations, everything is negative, then these patients are candidates for pure chemotherapy. However, if some mutation is positive, then you go for a targeted therapy or immunotherapy. The intent of treatment is palliation, but in situations where you are able to identify a target, the outcome is better comparatively.
So right, if they present early and they are, they come into your like chemotherapy and then they have a resectable tumor, so the chances of survival are much higher than what they come at a later. So anyhow, also the survivals are not very, favorable when it is not there are certain favorable malignancies of the pancreas which are more favorable for, survival or resectable. So you can put a little word on that as well.
So, pancreatic malignancies in recurrent or metastatic setting?
Or in the initial setting.
Initial setting, if it is a resectable disease, definitely the chances of cure are much higher. But so surgery alone definitely does not suffice. So you have to give chemotherapy. Chemotherapy has to be given in majority cases. You give perioperative chemotherapy, you give before surgery and you give after surgery. And in those patients where a surgery has been done and resection margins are negative, in such cases you offer post-operative chemotherapy to virtually to all patients. In rare cases where the resection margins are positive, then you have to have then you need to add post-operative radiation as well.
Right.
If it is an unresectable disease, these patients are managed with chemoradiation, but then it is again more of a palliative approach. So patients who have maybe a non-metastatic but unresectable disease generally don't have a very good outcome.
Right,
and
right.
intent is always palliation in such cases.
Yes, you're absolutely right. So was a very important thing for all of us to know about it. And now, what type of patients would you refer to a pain, for a pain physician, like when they present to you in your OPD for follow-up, or how do you decide that, okay, now this patient needs to go to a pain clinic or to go to a pain physician?
So I think virtually all patients who have got a recurrent disease, especially a recurrent or a locally advanced disease, they will definitely have some form of pain, and generally that will be moderate to severe pain. So I think all patients who have moderate to severe pain, these patients will be referred, and this pain will not be optimally managed with simple NSAIDs. So these patients will need some form of opioid therapy, and in some cases even opioid therapy may not be enough, so these patients will definitely need some kind of a block. So such patients will be referred to a pain physician.
Right. Thank you so much. And we know that the pain is, pain actually cannot be measured, but some idea can be taken about the severity of pain, because pain being such a multidimensional thing, it is not easy to put in numbers. It is not easy to put in colors. But then yes, along with pain, we need to see the symptoms, which symptoms can be not only pain, but fatigue, nausea, depression, feeling not bowel, drowsiness. So there are so many symptoms which these patients present with. And then they are put on morphine and the gabapentinoids, and the pain reduction is sometimes there. But sometimes, even in spite of putting up all the efforts of analgesics, still patients do not. And here comes the role of the pain physician. So I would like to invite Dr. Nimisha Verma, that now you have this type of a patient who has been tried on pharmacological agents, and now this patient comes to your busy pain clinic. Now, how would you, approach this patient, and how would you take this patient for the pain intervention procedure?
Yes, thank you, ma'am, for inviting me to give my opinion on this case. And for this kind of a patient who has already got a metastatic pain, he has got a recurrence, and he's already on morphine. I would like to assess from the very beginning. First, the most important thing is history when he comes to our OPD, to assess the type of pain, because when we assess the type of pain, then only we are going to treat it. So giving only opioids, giving only morphine or NSAIDs is not the way forward. It is what type of pain is there, because cancer pain can be because of the tumor itself. It can be because of the chemotherapy that is going on, and it can be a new pain also. So we have to assess. So for that, history is very important. How we go about the history? History is, we know Socrates, site, onset, duration, and aggravating, relieving factors. And then we go for examination and pain scales, as you have mentioned. So when the more important points that we focus on are what is the severity of pain. So our approach to intervention is when the pain is moderate to severe kinds. Okay, like it is more, if it is more than 7 on 10, the patient is already on morphine, then we go for pain interventions. Then second point of importance is what type of pain is there. What are the structures that are involved, and for that we need to do a radiology review. And third point is that we have to look whether the patient, how jaundiced is the patient, what is the level of hydration of the patient, and whether he has ascites or not, as they will decide what type of intervention we're going to do in the patient. And as we know that for any intervention, we have to rule out the contraindications like infection or coagulopathy or electrolyte imbalance and hypoalbuminemia. And especially if the patient has been on chemotherapy, there are chances that 1 week following chemotherapy, the patient may, because it is catabolic state of the body, so they might go into hypotension. So that 1 week period post chemotherapy should ideally be avoided for interventions. So that is my answer.
So, what interventions that you can give in these patients of having severe pain and coming to you with the, with
Yeah,
the
ma'am. If the patient has got pancreatic cancer pain, so the pain will generally be localized in the upper epigastrium, above the umbilicus, and it may radiate to the. So there are various approaches that we can use. We will be going for a celiac plexus neurolysis or a splanchnic plexus block. So and we, for to be very precise where to go, how to go, we have various diagnostic aids to our help. It can be a C-arm guided block, it can be an ultrasound guided block, which these two we commonly perform, but it can also be done with CT guidance and with endoscopic ultrasound guidance. The target, ma'am, please go to the previous slide. Yeah, the target is the celiac plexus, which is located around the celiac artery. The celiac artery is as we know, is the first branch of the abdominal aorta, which comes out at the level of T12 L1 vertebral body. So that is our target. That is how we approach, and why we approach celiac is because we want to treat the sensory nerves. We want to numb the sensory nerves by these neurolysis and the blocks. But in abdominal viscera, yeah, visceral pain, the sensory fibers go along with the sympathetic fibers to the spinal cord through the greater, lesser, and least splanchnic nerves to the sympathetic chain, and then from there into the dorsal horn of the spinal cord. The same path is followed, although they differentiate at the level of the sympathetic chain. So whenever we are putting a block, there are certain indications and contraindications. Indications is that in this patient, yes, we will go, because for all upper abdominal malignancies, we prefer celiac plexus. But there are certain contraindications also, like if the patient has a bleeding diastasis, or if there is a lot of tumor invasion in and around the celiac plexus, because if we put a needle there, then there are chances of we seed the tumor to the other places also. So that is what we should avoid.
Right.
Yeah. Coming on to the techniques of celiac plexus, so the commonly performed ones are the C-arm guided and the ultrasound guided. So C-arm guided, we take the bony landmarks. We can do a celiac plexus neurolysis. There are two types of celiac plexus neurolysis. One is the retrocrural, that is, crura is the diaphragm. If we if we approach the celiac plexus behind the diaphragm, which the crura attaches at the level of the L1 vertebral body. So if we go behind the diaphragm, then it is the retrocrural block. And if we pierce or go through the crura anterior to the aorta, then it is the anticrural block. So those are the various approaches we can see. It's posterior transaortic, bilateral, posterior para-aortic. We have the classical approach of Labart's. Then we have intervertebral, the transdiscal, which we commonly practice nowadays. And then we have the anterior approach, which is the ultrasound guided approach. So these are the various things. And we can see, these are the CM guided, and these are the ultrasound guided images. We can see that we have to locate the abdominal aorta, the L1 vertebral body, and we can see the first branching is the celiac artery. And through an in-plane approach, we visualize our needle going through the one side of the screen, and then we go in and around the celiac artery and deposit our local anesthetic or neurolytic block, which can be alcohol 8 to 10 ml, 70 to 50%. So the current evidence is in favor of the neurolysis, and celiac plexus neurolysis has an evidence of 2A plus, and neurolytic Slanknick nerve block is 2B. And early celiac plexus neurolysis has been shown to improve the outcome, but pain outcome is definitely improved, but the timing of the block and whether it is going to improve the life of the patient is still not clear. So this is
Right.
So madam is scrolling. So for any
Yeah.
yeah, for any block, one thing which the form has reminded me is that for any block or any procedure, we have to have consent, because this is generally not the anesthesia people doing it. It is a we have to take care of that consent, which is very, very important. And pain assessment, as I had mentioned earlier, can be done by various scales. And there are two types of pain. One is the nociceptive pain, one is the neuropathic pain. So celiac plexus neurolysis in pancreatic cancer, it is generally a mixed type of pain, because this plexuses are involved, and that is more like visceral neuropathic. And sometimes the tumor is so hard that it is pressing on the anti-abdominal wall, and that is somatic in nature. So both the type of pains are there, and depending upon what type, we have to approach it accordingly. More for somatic, we can go for an epidural or an intrathecal, if depending also, that will also depend upon what the life expectancy of the patient is.
Right. Thank you. Very nicely summarized, Dr. Nimisha. And you have said that it is better to approach at a time when the malignancy had not surrounded the plexus and you have an access to the plexus to block it, because once you have an invasion of the malignancy, then it may not be that useful, or maybe in fact not fruitful to the patient to have, for the pain relief. So I think that was a very relevant point that you said about the interventional pain procedure. And then there are other modalities which can be tried in those patients. Definitely, yes. Now, I just want to put a very burning question for all my panelists, like thinking that, when we have our patients in which we have done the patient is now in a stage where the tumor is non-resectable and the analgesic and the pain has been taken care of, and then patient symptom control are also being done. But then there is a family is also aware of the fact that now the patient is in a state of disease where the disease has taken more has taken overpowered the patient as far as these modalities concerned. So now when these type of patients whose survival may not be that is not expected, but then the family is there and they are not, sometimes the counseling is not being done at a time when they are able to understand the pros and cons of these type of patients. So what my question is, when you have these type of patients in your emergencies, and I'm sure anesthesia gets a lot of calls, even intensive care gets a lot of calls for these patients, how is your take? Like, I would ask one by one all my panelists, like Dr. Richa, then Dr. Lalita Gauri, Madam, then Dr. Nimisha, and Dr. Deemri. What is your take when you have a patient who comes with severe dyspnea, with having an end-stage disease, having no reversible cause at that point of time, how do you approach this patient?
Thank you, Dr. Vinita, again for a very pertinent question. Because yes, there are times when there are patients where we know that there is no, the patient does not have much chances. There is imminent death, cannot be avoided. So in these cases, the intubation is actually, you can avoid it at times, yes, because it will actually prolong the process of patient going peacefully. But on the other hand, one must take care that you can put the patient on high flow oxygen mask or NIV and give good pain relief, and allay the anxiety of the patient, which is so important to, so that they are not agitated, they don't have to undergo a painful journey of laying down to their demise. And then at times, preoperative intubation may be considered if there is, it is rare, but it may be considered if there is too much of respiratory distress. Definitely, if the patient is just not, uh, able to maintain even on NIV and they get too tachypneic, too dyspneic, then as an end of life, at times, according to the patient's relatives also, at times they will say, please intubate, but yes, it can be avoided. But it is, I think, a decision which has to be taken at that very point. One just cannot classify that I will intubate this patient, I will not intubate this patient. We'll try as long as we can with the analgesics, good analgesics and everything. And one thing I think which is very, very important, which everybody has mentioned, you have also mentioned, is that it is important to provide empathetic support to the family. I think if we counsel them well, if we tell them what is the actual this thing, how the course is going to go on, so usually the family members also understand, and they will tell ki theek hai, we go with whatever you are doing. So I think we need to encompass all of this.
Right, right. Thank you so much, Dr. Richa, for making it so, comprehensive. So now I would like to ask Dr. Lalita ma'am that what is your experience on these type of patients? Like, how do you deal with them?
Okay, so when we're in the ICU, typically, they always say, oh no, what is the percentage? What is the number? The people keep asking for a number of survival. So if you have an unplanned ICU admission for an advanced inoperable pancreatic cancer, it carries a 30-day mortality, which is more than 50%. And if they get intubated and are mechanically ventilated, and that actually reduces the survival time with the median survival, which falls to roughly about 11 days. So proactively engage the family and the hospital palliative care team. We have a full-fledged palliative department within the first 12 hours of these people arriving. And when we have a sick patient, one has to understand why did they really get sick. They don't really rubbish every inoperable case. So it could simply be acute cholangitis or a biliary sepsis or a pulmonary thromboembolism because these are very hypercoagulations. Or could be simply malignant ascites, which is causing diaphragmatic splinting. So just like Dr. Richa just said that, you can put them on an NIV or an HFNC and, take care of their pain, take care of their anxiety, but quickly do a bedside ultrasound, see if the biliary is dilated, one can probably do a BD or get an endoscopy, do an ERCP to at least control the sepsis, get antibiotics on board, look for, can do an echo, bedside echo, and see if it's pulmonary thromboembolism, or simply just drain the ascites and relieve the diaphragm. So sometimes they just come into your ER or to your ICU, and you can do something very momentarily, and then maybe they just give them a couple of more time to survive. But having said that, when they really come to you sick, make sure that the family is on board with you quickly, and they understand the futility of care. They understand what the status of disease. So we very typically ask the patients, the first thing we ask, what do you understand about the disease? What do you understand what is happening to the patient? What do you understand the treatment that we're giving? What is it actually doing to the patient? Will you be able to take this patient back home? And from there on, one can quickly transition, or, it is sometimes easier to transit to a comfort-directed care plan once they really understand that any kind of invasive intervention in the face of this disease progression is kind of futile. So we fortunately have a palliative care department. All our patients go through JC, and patients who are our own patients, we would know on the file whether a palliative intent has been declared by the JC. And so it's sometimes easier for us to counsel the patients, and when we get and when and in this subset of patients, we tend to counsel them together. So whether it's your surgeon, whether it's a medical oncologist, whether it is your radiation department, and us, we do a joint counseling. And sometimes then the relatives become much more, they understand, they are on board with you quickly, and we can avoid an unnecessarily intubation and prolonging the agony of this subset of patients.
Yeah, completely. I agree with you. The dignity to live and the dignity to die is the domain of the patient. And if they have an advanced, thoughts about it, it becomes much easier for the team also and the family also to decide whether they have their responsible, caretakers with them who can make decisions in a situation where the patient is when the patient is cognitively impaired. So, Dr. Nimisha, how would you, provide with the palliative sedation just if the patient doesn't have a reversible cause and the family is also distressed, looking at a patient who is in dyspnea and they request you for a palliative sedation? How would you go about it?
This is a very difficult question that you have asked, first of all. The decision to do a palliative sedation at the time of the presentation at emergency is not the right time to decide whether we have to go for palliative sedation or not. This has to be done before, when the patient is in better health, when the family is okay. Then whether they would like to go for palliative sedation or end of life sedation, or they don't want. So that has to be written in the advanced care directives, as has been approved. Now our government of India has provided us provisions to give advanced care directives. So that is one thing. Secondly, our treatment should be aligned if the patient presents to us in the late stages of his life and there is palliative intent of treatment has been declared, then there are two steps. Whether we just want the palliation of breathlessness or we want terminal sedation or palliative sedation in this patient. For palliative breathlessness, we can go for 1 to 2 milligrams of morphine. First thing again, when the patient presents, we have to correct the correctables first. So what are the causes? Whether is there something which is hypoxia, or there is rhonchi stridor, or there is obstruction, then we have to correct all those things. If yes, we know that the disease has progressed so much that there is no hope and the palliative intent has already been declared, then first step is to treat breathlessness, which can be easily done by morphine. Most of the times the patient knows his end is near, and the most important thing is to allay the anxiety. So for that, benzodiazepines can be used. For very agitated patients, we can use propofol, and for that is for palliative sedation. If the patient is only breathless, we can use 1 to 2.5 milligrams of morphine, subcutaneous or slow IV, to treat that breathlessness. It can, if that helps, then we can go either for a continuous infusion or we can go for an intermittent bolus as well. So this also is very controversial because it can be compared. Palliative sedation is somewhere it can be confused with physician assisted dying or active euthanasia. So all those factors have to be discussed before we opt for palliative sedation, rather than deciding it on the table or in the OER when the patient comes to us. That is not.
Yeah, all these things need to be done beforehand. They are not to be done in this kind of a situation. These things should be discussed with the family and the caregivers much when the patient is in a state where they can make their decisions. So that is very, very important. Yes, and even if they are done by the, by the allocated caregivers, it has to be documented and it has to be explained, and should be, very well mentioned. So now, Dr. Dimri, this is just the last question, and we are almost 1 minute ahead. I mean, we should be finishing it by now, but then we're just 1 minute more than that. So, Dr. Dimri, the same question is to you also at the last. So, can you just sum it up, right?
Yeah, so first we need to identify the cause for dyspnea in a patient with metastatic cancer. according to the reason, then we give the treatment, appropriate treatment. So dyspnea could be because of pleural effusion. So in such cases, you need to do a pleurosynthesis and maybe a pleurodesis. A lot of these patients, they present with a solitary lesion, maybe a large solitary lesion which is obstructing one of the major bronchus. So, and or they may present with extensive lymphadenopathy leading to SVC syndrome, SVCO. So in such cases, palliative radiotherapy is quite effective. I mean, it is not for cure, but definitely it elevates the dyspnea which is associated with the disease. Then in those patients who got multiple lung metastases, in such patients, maybe bronchodilators are helpful. And as the previous speaker has, panelist has enumerated, opioids have a very important role, and maybe benzodiazepines for elevating the anxiety. Some patients who have very advanced disease, they will present with lymphangitis carcinomatosis, which is like diffuse involvement of the lungs. In such cases, steroids definitely have some role to play. And in those patients where the dyspnea is refractory to the other forms of treatment, then we need to rule out PTE, because pulmonary thromboembolism, because that is again a known complication of advanced metastatic disease. So in such cases, if it is there, then you treat accordingly. Oxygen supplementation has some role, maybe in those patients who are hypoxic, but it's more of a supportive thing rather than a definitive approach for managing a patient with dyspnea because of metastasis.
Yeah. So I think we come to the end of the panel discussion, and I would like now the chairpersons to give us their experience and their inputs.
Well, Dr. Vanita, it was a very elaborative panel discussion, and I'm very hopeful that audience would have learned a lot out of it. My question to Dr. Namisha is that it would be a good idea if Dr. Namisha could highlight what is the role of opioids when it comes to cancer pain management, chronic cancer pain management. What is the role of opioids? Where does she prefer to use opioids? If in a patient who is in terminal stages for management of cancer pain.
So, hi Jitendra, please come up again with your question, because there are two aspects to it. You want me to answer the opioids for cancer pain management or opioids for terminal breathlessness? That is what I want to clarify.
Cancer pain management, opioids for cancer pain management. Yeah.
So for opioids for cancer pain management, we'll go by the analgesic ladder. And if depending upon we generally follow the numeric rating scale. If the scale is, if the VAS or the NRS is less than 3, we prefer simple paracetamol or NSAIDs. If it is 4 to 6, then we can go for mild opioids, sometimes tramadol. And then if it is more than 7, then we go for morphine, buprenorphine, maybe fentanyl infusion. So that is all what is available to us. That is the algorithm that we follow for cancer pain management.
But Dr.
Okay.
Nimisha, just want to pitch in. See, when the patient usually comes to us, to be honest, he would have exhausted everything. And most of the time when the patient is referred to the pain clinic, it is either post-operative with the recurrence, inoperable, or CT done, inoperable, and referred to pain clinic, that it is a spread out thing. And our experience has been that opioids are the mainstay. Once patients come to you, the pain score is already 6, 7, 8, 9.
Yes.
And no need. My suggestion to all is that please do not worry about the opioids. Please do not start at 5 milligram BD dose. Morphine has to be given 6 hourly, 4 hourly. Please give it that way. You can start with a low dose and go increase. And practically, to be honest, we have tablets of 10 milligrams, 20 milligrams, 30 milligrams SR and 60 milligrams SR. So those tablets are meant to be used only. And yes, at times you have to use 60 milligrams SR 4th hourly. That means 360 milligrams of the. I think somebody is sharing something.
Yes, sir. I would like to add to it that.
No, I have not completed. Somebody was
Achha.
sharing the screen. So, but there comes a time when patient is not getting relieved by morphine also. Now, morphine, to be honest, it is a very wonderful drug. Even if it is a jaundice, And please do not worry about the sphincter of Oddi spasm and all those things. It gets metabolized even if 5% of the liver is functioning, if there is a liver mets. So do not worry about that. And please do not worry about the respiratory depression also. And it has to be combined. Yes, always better to combine paracetamol with that. Always better to combine gabapentin and nortriptyline in the night. Please do care of the opioid-induced constipation also, and opioid-induced some tolerance will also be there. We have to take care of that and take care of the breakthrough pain also. And if patient is not getting adequate pain relief, please perform celiac plexus block as early as possible. You can do both. We are tuned to doing it bilateral fluoroscope guided under in prone position. Yes, but if you can do USG guided also. But please do it. And whatever the lifespan of the patient is, make him or her pain free. Because if patient is in pain, relatives are in more pain. There will come a stage when even after performing celiac plexus, or in some patients you are not able to perform celiac plexus. Patient was operated, there was a burst abdomen, and only interrupted sutures are there. So patient cannot lie down prone. In there's open surgeon says that everything the guts are there. Patient has got Ryle's tube, and you are able to nothing NPO is there. So you cannot give a celiac plexus block in that patient. You cannot give a oral morphine in that. Please crush the oral tablet of morphine, mix it with a drop of honey, and give it sublingually. There will be some absorption. There will be some absorption. You have got options for tipentadol nasal spray also. 20 milligram spray, alternate nostril. Every fourth hourly you can give, maximum of 200 milligrams. There are cannabinoids also. Biscayne drops are also there. You can start at 2 drops HS and go as high as 16 to 20 drops per day. So don't, and then definitely you can add on with the buprenorphine patches also. But yes, we understand these patients at times go into hyperpyrexia, so absorption can be there. So just keep a watch on the temperature. And terminally ill, finally, at times you may have to go for intravenous infusion of fentanyl. I would have said that we have exhausted the stage of buprenorphine and fentanyl patches, and you at the end you may have to go for IV infusion. But that IV infusion cannot be given at home. That is in the centers where patient is admitted. So we have to follow the patient from the OPD and maybe at times, unfortunately, till the deathbed. So, and there are so many other things which come up, but you have to be in regular touch and ensure the patient has got a pain-free life and pain-free death. Thank you.
Sir, Naveen sir, I just want to add one thing. I'm Dr. Dheeraj.
Yeah.
Sir, in many Western countries now, what they're doing is they are adding subcutaneous infusions of ketamine. That's an adjuvant which is being used in subanesthetic doses, especially in inoperable, in which we cannot go in even for the interventions. As an adjuvant with the morphine, which is given, so subcutaneous, even they are mixing ketamine with the opioids so that the side effects, especially respiratory depression, can be reduced. And another thing just want to add is the role of intrathecal non-opioid like ziconotide, which is still not there in India, but maybe it is still in many advanced centers being imported from many European countries. The intrathecal ziconotide, which is being used especially in those conditions in which the cancer have been gone into very advanced stage where we cannot go for even interventions, and the patient is not there is no effect of the morphine or other modalities. So just wanted to add this, that this subcutaneous infusion pumps are available for Parkinson patients for apomorphine drug, which is being given for them. They are available, but still it is being not used in the pain centers, many of the pain centers in India. But some of the pain centers are using, but in Western countries, very commonly used very small pump, which can be attached to the patient itself. And those particular pumps are there in the hospice, and they can even go to home with those pumps, and that have given a very good analgesic effect, what have been seen in many Western countries and their experience. Yeah.
Thank you, Dr. Dheeraj, for adding to the armamentarium. See, I personally agree with you that subcutaneous ketamine is a very, very practical and effective adjuvant. Intrathecal pump, the only issue comes is about the affordability. To be honest, uh, availability you are talking about is
Yeah,
going to buy,
cost is
but
also very high.
yeah, but even if we have an intrathecal pump placed and you can simply give morphine through that, and that will take care of everything. But how many of practically people, because you please understand, these people have undergone surgery, these people have undergone chemotherapy, and when they are financially drained out, then they are referred to the pain palliative and hospice care. So, but yes, if a patient is under some panel or some reimbursement, if patient can afford intrathecal pump, then there is, to be honest, intrathecal morphine itself is a very, very beautiful drug.
Absolutely, absolutely, sir.
It's simple, effective, and it will take care of the whole of the lifespan.
Yeah, sir. But I think, sir, we should press on ziconotide also in future, because it's a calcium N-type calcium channel blocker, which is being used as a spinal cord itself, reducing the neurotransmitters which are causing this pain on the primary efferent neurons. And it is being in vogue now in many countries. Maybe in future we should press on
Yes,
having
definitely.
ziconotide. Yeah.
I agree with you that we should have all things, and if patient can afford it, then it should be offered to him. Thank you for those inputs.
Thank you, sir.
So I would like to thank our esteemed chairpersons, our speakers, our participants, our students for coming all together.
विनीता मैं एक बात और ऐड कर देता हूँ. Please, those who are not in institutes or medical colleges, please don't worry about the availability of the morphine or about the buprenorphine. If you have got a hospital, you got a pharmacy, you can keep a buprenorphine patch, and with your own medical council registration, you can have cannabis with you. You can have a fentanyl patch also with you, and you can, with your state specific form D, you can prescribe morphine tablets where patients can go. In each state, there are different chemists who are authorized to keep the opioids, including the fentanyl patches, morphine tablets of all things. Now, pethidine is not being used. Fentanyl lozenges, remifentanil for anesthesia point of view. So you can fill that form. Simply, you have to write the name of the patient, the diagnosis, the OPD number or the registration number, which thing has to be given. So, suppose morphine 30 milligrams, 100 tablets, and don't write more than 100 tablets. Below that, you sign your name and you put your registration number and sign and stamp it. Keep one copy of it with you. So, those who are not in government sector, you can always ensure that your patients also get morphine, and morphine is a very cheap drug. It is not costly at all. So please do not worry about the availability of the morphine. Please do not shy from prescribing morphine, and do not worry about the side effects. पेशेंट को रेस्पिरेटरी डिप्रेशन बहुत रेयर होता है, सो डोंट वरी अबाउट दैट. हाँ, कॉन्स्टिपेशन यू हैव टू टेक केयर, अर्टिकेरिया यू हैव टू टेक केयर. सो प्लीज गिव लेवोसिट्रिजिन एंड बिस्कोटिल सिरप preemptively, and please do not delay the intervention. You choose celiac plexus, you choose splanchnic plexus, that is your choice, whatever you want to do, anterior approach, posterior approach, but don't shy from the interventions.
Sir, any of your experience of opioid-induced hyperalgesia in these patients?
Yes, very, very common, very common, very common,
Okay.
very common.
Okay.
Very, very common. It is seen. Even these patients also have at times breakthrough pain also. Especially when they're doing some unaccustomed activity or some mild or moderate intervention is done. Usually they will be on a sciatic tap, some or they will be having pleural effusion, and with that dyspnea, some local they go to local hospital and get a sciatic tap done to decrease the dyspnea and respiratory discomfort. So they will have those types of breakthrough pains also, and we always say that take an extra tablet of the dose which you are taking. So 10% of the dose which you are taking, if you're taking 6 tablets in a morphine, take an extra tablet, or if at all you can take a tapentadol nasal spray. Patch usually because it works for 1 week. So with that is also useful, but these are immediate measures where patients feel comfortable.
Sir, I think still we are lacking in the opioids as such, oxycodone, OxyContin, which can be used as an opioid switch therapy, especially in OIH. I think, sir, still we have only having a morphine and methadone at present with us. And maybe in future, if we have this oxycodone and long-acting OxyContin, which might be effective in these patients, especially when they switch therapy in OIH. Isn't it, sir?
See, it's now 22 years I've been born in pain medicine. I've been listening that oxycodone and oxycontin will come. I don't know when they will come. I'm very honest with you.
Yeah.
Whichever lecture I used to listen, 10 drugs, 9 are not available in India. So I used to think, why you're talking about these drugs? Tell me which is available in India.
Yeah,
So I know that's a challenge which we have to
challenge.
follow.
Yeah.
But to be honest, over the last 2 or 3 decades, still patients who are having cancer pain, they are being catered to. And I request, take this opportunity to motivate also. So those who are in anesthesia, please take up pain medicine as a career. It is a beautiful field of anesthesia. And in that pain medicine also, you can choose different things. You can be an interventional pain specialist, you can be a cancer pain specialist, or you can go to the palliative care also. So, to be honest, now I am under pressure कि sir आप एक make a 10-bedded hospice for end of life care. तो मतलब अभी time and but people want that why they should go to there should be services at their own city level where they can be catered by specialist nurses and specialist doctors, and they're ready to pay also. So, and yes, government has also come up that they're ensuring that palliative care units are there in all government civil hospitals and medical colleges. But already with having beds is one thing, but we need more staff also to be recruited for that thing. Deputing the same staff to that place won't help. So, but still, government is also thinking over it, and I'm very sure that as a pain physician, we should take lead in taking care of the patients who are in pain, and don't make them wait outside the OPD. See them out of turn because already they're suffering. It takes 3 to 4 people to bring the patient to the OPD, and don't call the patient every time. Once you have seen it, you can ask the attendant to come, and the attendants can brief you well. Until unless you're going to do some intervention, you can modify the drugs, listening to the history by the patients also. Okay, how much time patient is getting pain relief? Okay, duration is getting less. So don't make these patients wait, and please do not call the patient every time.
So, so should I now conclude?
Yes. I have expressed myself.
Right. Thank you so much, sir. I would like to thank Dr. Kaul, sir, also. I saw sir on the, on the
My
page.
sir is very much here.
Yes, sir. So I would like to thank Dr. Tej Kaul, sir, for being with us and and being on the webinar. Dr. Naveen sir, Dr. Vishal sir, Dr. Sanjeev Palta sir, Dr. Babita Ghai ma'am, Dr. Thapa sir, and all the speakers, and the faculty who participated in the webinar, all students. So I think it was a very, very engaging session, and I really had a great academic interaction. So thank you so much.
I think Dr. Tej Kaul just switched on his video. So, sir, if you can bless us with your
excellent webinar. It was an excellent webinar, very informative for all those who practice pain medicine and those who do not practice pain medicine. It was very informative to everyone. Every participant, every chairperson did a great commendable job. I enjoyed attending it. Thank you. God bless you. Long live RSA.
Thank you, sir. Thank you very much.
Thank you very much, sir.
Thank you so much, sir. Thank you, sir. It's
Long live RSA and good night, please.
good.
Thank you.
Thank you.
Thank you. Long live
Thank you
RSA.
very much.